Our next speaker will be Dr. Stephan DuPlessis. Did I say that correctly?
Perfect.
Perfect. All right, it's good. He's a clinical associate professor of neurosurgery at the University of Calgary.
This one? Put this down. Thank you very much for having me. It's a privilege to be here with everybody. I work closely with Farnaz. I think I'm learning a lot from this conference, different aspects of the approaches that everybody has. We're getting to the surgical part of things, and as you guys maybe know, surgeons sometimes think a little different about things. We don't always agree, but let's go through the slides and show you some. You see there. Yep. So no disclosures. I am a member of the advisory board for the CSF Leak Foundation. And so what shapes a surgeon's mindset? There's a few things that's important. When we're talking about surgical issues, then surgery carries a fairly significant risk, more risk than Botox injections or epidural blood patches. So personality and surgical philosophy drive definition of success. The nature of surgical interventions, there are typically significant risks of complications, and surgeons tend to want to look for a favorable risk-reward ratio. Want to minimize complications, and most surgeons are typically interested in patients or conditions that will have a good to excellent outcome with a surgical intervention. Surgeons differ in their approaches, and that's based on experience, level of comfort, and past complications. From a surgeon's perspective, I think we don't have many surgeons here today. I think there's 3 of us, and I think maybe somebody else that may be around. Good, was another person. So I think we have to have an open mind when we treat patients with complicated conditions, and it means adjusting our expectations with regards to outcomes, as well as make sure that we actually discuss that with patients as well when we offer them surgical treatments. Multiple repeat surgery is not uncommon when we're managing patients with SIH. So the surgical success rate is highly dependent on knowing the exact location of the leak. And the exact location of the leak is, again, highly dependent on the imaging findings. It's really important to appreciate that. High surgical success rates are usually associated with type 3 leaks, the CSF venous fistula, and then type 1 leaks and some of the type 2 leaks as well. So high surgical success rate, intradural, intraspinal, dural defect clearly identified, a ventral leak, or a proximal nerve root sleeve, dural cyst or leak. There's a positive clinical diagnosis, positive brain findings, positive spine findings with a positive SLEC, and then the DSM or dynamic CT myelogram did show where the pathology is. That gives us a precise surgical target. Extraspinal pathologies, CSF leak is clearly identified, but typically these are the SLEC negative patients. Clinical diagnosis is positive, brain findings typically positive, and these are the patients with the fistulas or the distal meningeal diverticulums, and then certainly they almost have positive DSMs or dynamic CT myelograms. The moderate group, as we go down from a high probability of success down to the moderate and the lower probabilities of success, you'll notice that the imaging findings become more and more negative. So in this group, these are patients with a positive clinical diagnosis, positive brain findings, positive SLEC, but negative DSMs or dynamic CT myelograms. Typically, these SLEC lesions may be in an area where there's a high probability of finding pathology. For example, in the cervical thoracic spine, where we commonly see that there may be osteophytes causing defects, and also with meningeal diverticulum. So these patients are sometimes candidates for an open, in my wording, for exploratory surgery at high probability areas with osteophyte resection, diverticular clipping, wrapping, or just for the exploration and creation of scar tissue. The patients that typically have a low chance of surgical success is when there is a lack of supportive, significant lack of supportive imaging. So the most significant patients would be the patients that's got a positive clinical diagnosis but negative brain imaging, negative spine imaging, negative DSM, CT myelograms, and negative areas where we can look for a high probability lesion. So I want to just emphasize again that the presence of a spinal longitudinal epidural collection is really important. From a surgical perspective, it tells us where the CSF is leaking from, and also gives us a bit of an idea of how to approach this patient, because if the CSF is collecting inside the spinal canal, we'll typically take an approach of an intracanal approach, which typically would mean a laminectomy, or certainly sometimes a costal transversectomy to approach a ventral leak. Whereas if the CSF is external to the spinal cord, then sometimes a paraspinal approach may be a better approach. So further with regards to surgical thinking, so important to think about the probability of success as we approach a patient. If we have a high chance of success, the next thing to do is we've got to select an approach. And typically for surgery, what we are looking for is we're looking for the best trajectory that will give us access to the pathology without putting spinal cord or nerve root at risk. Next thing to consider is either open surgery versus minimally invasive surgery, and what is the most effective way to do the surgery. Certainly we want to minimize the amount of unnecessary tissue destruction that is sometimes a part of doing big surgical procedures. And then once you get to the site of the leak, how are you going to close that? Are you going to be able to do a direct dural repair, or do you have to do an indirect repair? So when looking at surgical approach, this varies quite a bit. If you look at the different regions in the spine, we have cervical spine, we have thoracic spine. Cervical thoracic junction is an area that we often identify these leaks. And in most cases, the pathology is approached either posteriorly or posterolaterally. In very rare circumstances, a lateral approach or an anterior approach. Anterior approaches will typically be in the cervical spine, where it's relatively easy to access the spine from an anterior approach. And then specific areas, as I mentioned, that we think of as cervicothoracic junction. That's an area that is really difficult to approach from anterior, and it's typically either a far lateral approach or what's referred to as a costal transversectomy approach. Other things to think about is the level of the spinal cord. It is typically easier to retract dura and work anterior below the spinal cord level. And then the other important part is also eloquent nerve roots. Certainly in the cervical spine, especially as C8, T1 levels, hand function is really important, so we don't want to injure any nerve roots at those levels. So the types of surgical procedures that we do, traditional open surgeries, those allow us to do maximal exposure. It gives us lots of flexibility with working inside spaces. It's a good option for any leaks, specifically complex leaks. I think Wouter is going to talk about complex surgical leaks. It allows us to do some exploration of exploratory surgery and potentially some dural reduction surgery as well. And then open surgeries allow for direct dural repair. We can do intradural repairs through an open surgical approach, as well as it's just a lot easier to suture a dural defect with a more exposure of the thecal sac and the dural defect. minimally invasive surgeries. Most of us do minimally invasive procedures. Eric is going to give a talk on minimally invasive procedures, and from my perspective, I think that these are a good option for simple leaks. Sometimes osteophyte resections. I do minimally invasive procedures for most of my CSF venous fistulas, and the direct repair can be difficult to do that through a tube, but usually what we do with those is either you can clip the fistula, or otherwise you can do an extradural patch, and that's a combination of a packing, as well as gluing of a defect. So surgical approaches by the type of leak. This is an example of a patient that presented with an anterior epidural fluid collection. The myelogram that we ended up doing couldn't really tell us at which level exactly the leak was, and there were osteophytes at both the levels, at C5 and C6. I'm always reluctant to approach cervical spines from posterior, especially if I have to work directly in front of the spinal cord, so I prefer an anterior approach. That means that we have to take out disc and we have to reconstruct this. In this patient, we did a single-level corpectomy and identified a really nice puncture hole into the dura, and we could close that directly, and that was excellent visualization, and we don't have to navigate around the spinal cord, but it does imply that the patient will have to have a fusion with loss of 2 motion segments. For type 2 leaks, these are typically approached from posterior posterolateral. This patient this was an eloquent nerve root, T1 nerve root, diverticulum. You can see at the back there's a dorsal epidural fluid collection, and then the arrow on the axial cut shows a defect in the posterior sleeve where the CSF is escaping dorsally with the dorsal slack, and this was closed with a combination of suturing, packing, and gluing. This patient is an interesting patient. This was a minimally invasive approach that we did. This patient was approached posterolaterally. Initially, we did the myelogram, and the myelogram was negative, and when we looked at the CT myelogram that was done afterwards, you saw this hyperdense paravertebral vein at the L5 level following the L5 nerve root out. And certainly we can't sacrifice the L5 nerve root, but on surgical exploration and looking at it, we found a nice dilating vein that was following out into alongside the nerve root, and the vein was just cauterized, and the patient did very well. This is done through a tube. Tube varies between 18 and 20 millimeters in diameter. So once we get there, there's ways that we have to see how we can close the defect. There's different ways to do that. We can do a direct repair. You can do an intradural direct repair or an extradural direct repair. That typically means suturing. Indirect repair is usually done extradurally, and then we have a whole combination of sealants that are available. The techniques vary from surgeon to surgeon, but most surgeons use a combination of techniques, either suturing with gluing and some packing as well, so a combination of things. And then when we're looking at the dural defect, sometimes the dura is just very frail. It's hard to suture it. Sometimes dural tears are nice longitudinal tears, which is easy to close in a watertight fashion. But often it's hard to close the dural defects just by suturing primarily. So we always try to glue and pack them together as well. The idea is to create some scar tissue as well. So direct dural repairs, the gold standard would be, or the ideal would be, to suture it and close it in a watertight fashion. We also use titanium clips, either aneurysm clips or vascular clips. It's relatively easy to apply aneurysm clips. They can be repositioned, and when you compare that to traditional suturing, and I think they're small enough not to have an effect on post-operative imaging, because we may want to image these patients after we have done a repair in case they have additional symptoms or develop more symptoms. And then there's also some newly available suturing tools. One that is available, it's not available in Canada, it's called the Durastat. It's kind of an automated suturing tool that you can use through a tube, which helps with suturing. The picture on the right is a dural reduction surgery. That's a modification of Voter's described technique. I use aneurysm clips for that, and I also support the aneurysm clips with Liga clips to prevent them from sliding off the dura. Indirect dural repair. These are typically patches and grafts. We have pathologies. The risk of infection, immunogenic reactions are rare. Fat grafting has been used for many years in other areas, plastic surgery, muscle grafts. Fascia can be used to suture in and over a defect. And then we have synthetic substitutes for that. Collagen, gelatin sponge. There's polyglycolic acid sheets, which is commonly used. We refer to that as a hemo patch, which is a sheet that's covered with glue that interacts with the dura and provides a seal. So a combination of sometimes collagen and some fibrin as well. Indirect dural repair sealants, like Dr. Callum described in his nice talk. The sealants polymerize over the dura and it covers it. We have biologically absorbable sealants that contains fibrinogen and thrombin. And then we also have some synthetic absorbable sealants that contains polyethylene glycol. It appears to be a bit more adhesive than the fibrinogen types of sealants that is currently available. We don't have that available, as far as I know, in Canada. I don't think that is approved. So tips and tricks, I kind of look at this as sometimes trying to find the needle in the haystack. Sometimes there is a large needle in the haystack. Sometimes the haystack is small. The biggest challenge is to manage patients with where we have convincing clinical symptoms, but the imaging is not supportive and it does not show us where to go and offer them a treatment. From a surgeon's perspective, it's kind of frustrating because it can be anywhere really along the spinal axis, and it's hard to justify doing a surgery if you don't have a good target, given the risks and things that are associated with it. So these are just some examples of based on my personal experience, that I've kind of tricks and things that I've tried and to try to localize leaks and repeat myelograms and so on. So I think for myelogram negative patients, I think it's important to understand that you may have a negative myelogram because you don't have flow across the leak. You need a pressure differential to have flow across from a high pressure to a low pressure area. And I think ways that that I've used in the past is to increase the pressure differential across the leak by intrathecal pressurization. I do that through a lumbar infusion, through an infusion pump, try to fill up the CSF volume, and sometimes that increases the chances of detecting flow by following up with a myelogram. I actually leave a pediatric arrow catheter in the intrathecal space, and that helps us infuse. Radiologists can also inject the intrathecal contrast through that, it also gives us a clinical test. If I infuse somebody with lumbar with low pressure and their symptoms improve, especially when we get them from a supine to an upright position, it tells me that I may be dealing with a compliance issue as opposed to just a straightforward leak. The other thing that that's caught me in the past is the timing of blood patches versus myelograms. I think if there is, I think we have to think about, when do we do a blood patch? Do we do a blood patch what's the timing between a blood patch and a myelogram? Should we be doing blood patches if we're planning to do a myelogram, or should we just do the myelogram as soon as we can, or otherwise maybe just delay the myelogram until we have symptoms, because I think we can have a false negative myelogram. And then I also try to individualize patients and try to do the investigations when patients are maximally symptomatic. I think if we would do our imaging maybe towards the end of the day when most people have got more symptoms, we may have a more positive findings, but who knows? That's up for debate. The other thing I do look at also is I look at the lumbar cistern volume capacity. In some patients, if you look at the lumbar spine, there's a huge lumbar cistern. If you have a huge lumbar cistern, you may have more, without detecting a leak, you may actually be dealing with a craniospinal compliance issue otherwise. And then I also consider doing a radio nuclide cisternography for patients if I'm not sure if they have a leak. I'll just go through the pitfalls quickly. We've gone through this some. So these are diagnostic pitfalls, operative pitfalls. The biggest thing I think, we know subdural fluid collections are a pitfall, Chiari malformations is a pitfall, and then post-operative things. Sometimes we run into problems with increased intracranial pressure, and that's some pictures of subdural effusions, fluid collections. Tonsillar descent in Chiari malformations due to brain sag as opposed to a posterior fossa anomaly. And then I think this is something that is, I think, important when postoperative intracranial hypertension. Are we actually dealing with a primary problem of intracranial hypertension that presents following a leak with intracranial hypotension? I have quite a few patients that I think that may be the case. Or are we actually dealing with a rebound intracranial hypertension? And then the other thing that I've run into trouble with in some patients is when a low-pressure subdural hematoma becomes a high-pressure subdural hematoma, which needs some drainage. And that's it from my side. Thank you.